So now I'd like to introduce to you my boss, Dr. Joe Parks. And he serves as the Chief Clinical Officer for the Missouri Department of Mental Health in Jefferson City, also holds the position of Distinguished Research Professor of Science at the University of Missouri St. Louis, and as I said, he is the Director of the Missouri Institute of Mental Health. Also serves as Clinical Assistant Professor of Psychiatry at the University of Missouri, Department of Psychiatry in Columbia. He serves as the President of the Medical Directors Council of the National Association of State Mental Health Program Directors. He practices psychiatry on an outpatient basis at Family Health Center, which is a federally funded community health center established to expand services to uninsured and underinsured patients in the Columbia area. He recently served as the Division Director for the Division of Comprehensive Psychiatric Services for the Missouri Department of Mental Health. I could go on, but he's got a lot more to tell you, and so I'm going to hand the floor off to you, Joe. Thanks.
Okay. Thank you very much, Tom. It's a pleasure to be coming to you today from the Missouri Institute of Mental Health, and I'm really pleased to be talking about behavioral health and primary care integration. First, I'm going to say a few words about why it's important and why it's necessary, and then I'm going to go over two models that we've implemented here in Missouri to achieve integration of behavioral health and primary care. I won't introduce myself again since Tom did such a good job of it. He did mention that I'm with the National Association of State Mental Health Program Directors. I want to tell you briefly who they are. That's the organization that represents the people that run the departments of mental health in the 50 states and 4 territories. They represent the $23 billion public mental health service system, and they serve about 6.1 million people annually. And a lot of the material I'm going to show you was developed by the Medical Directors Council, which is the part of the organization that advises the commissioner on clinical matters, how to improve treatment, and what the appropriate standards of care. The information I'm going to give you in the first half of the talk can be found in the morbidity and mortality report for people in serious mental illness that's on the NASPID website. If you can't write down all that long address, just go to nasmhpd.org and go to publications, and you'll find the morbidity mortality report. So an overview of why integration is important is people with serious mental illness die younger than the general population and have a heavier burden of sickness. Most of that early death and increased sickness is due to metabolic disorders, cardiovascular disease, diabetes, modifiable risk factors like obesity and smoking, and really the mentally ill have an epidemic within the national epidemic we're having. We've all gotten heavier, and that's increased everybody's disease burden, and the people with mental illness just got there quicker than the rest of us. Some of the medications we prescribed in treating mental illness increase weight gain, and that adds to cardiac risk. And perhaps as importantly, people with serious mental illness don't get the recommended preventive screenings and best practice treatments for chronic medical illnesses at the same rate that the general population does. They're less likely to get the kind of care that's best for treating chronic illness. This really came to attention nationally as part of a multi-state study that was done, that was published back in 2004. It was done by the NASPID Research Institute by Ron Mannerscheid and Dr. Coltrane. And it looked at the mortality rates of Department of Mental Health, people in the public mental health sectors in 8 different states: Arizona, Oklahoma, Texas, Utah, Missouri, DC, and it compared them by what's called a standard mortality ratio. This is a way of adjusting populations for age and gender differences, so the rates are similar even if the populations have some different age and gender characteristics. This was converted to years of life lost. How much earlier are people in the public mental health system dying than the comparable people in the general population? And in all the states, the answer comes back about similar, about 25 years earlier, across multiple states, across multiple years. This was shocking, and this is why we call it an epidemic. This is about the same rate of age of death as in sub-Saharan Africa, and is more loss of life than we currently see in populations with HIV. Furthermore, it's worse than the situation was 20 years before this study was done, when people were dying more like 15 years prematurely. Another way to look at it is standardized mortality ratios. How much more likely is a population to die than the comparison population? And across these 7 states, the people in public mental health are 2.2 times more likely to die at any given point in time than people in the general population. The aggregate average number of years lost is 25 years, with an average age of death of 56 or 57 years of age. So this shocked everyone when we first saw it. The results were run twice to make sure it was correct, and then broken out by illness, because we thought, oh dear, has suicide really become that common? It's much higher than we thought. Well, the next surprise was the major cause of death was heart disease. You see that in the total group, there's about 48,000 total years of life lost, 48,800, and of those, approximately a third, close to 15,000 years, are due to heart disease. Suicide accounts only for 10%, 4,700, with the rest of it, the bulk of them being other chronic medical illnesses, by far leading over accidents and suicide. Now, how does this compare with changes in longevity in the general population? This shows the results of one of the great public health victories of the last several decades. Heart disease deaths are way down. This shows coronary disease and stroke declining by about 50% between 1979 and the mid-90s. At the same time, other causes of death were staying about even. So if you're in the general population, your risk of dying of a stroke or heart disease dropped in half during that time. If we compare that to people that had schizophrenia, we see their death rate going up both for cardiovascular disease and for all causes. The graph on the left is for men, on the right for women. The white bars is for all cause of death, and the yellow bar is for cardiovascular disease. So at a time when for the rest of the nation, cardiac death is going down and all deaths are remaining stable, for people with schizophrenia, cardiac death is going up and all-cause death is going up. This is really a public health disaster and deserves to be called an epidemic. Maine took the study to its next step and decided to look at people before they die, while something could still be done. In this study, they compared people in their Medicaid program who had a serious mental illness, the red bars, to people who in their Medicaid program who did not have a serious mental illness. The advantage of this study is it, in a rough way, controls for socioeconomic factors. In general, people who live in poverty die younger than people who don't live in poverty, and in general, people with serious mental illness are more likely to be in poverty. So how much of this is a poverty effect as opposed to a mental illness effect, if it is indeed possible to disentangle the two, which I doubt, frankly. But in the Medicaid program, nobody has much money. So this, in a way, controls for that poverty factor. And we see that across all different areas of disease, whether it's skeletal connective tissue, arthritis, if you would, GI disease, stomach disease, obesity, congestive obstructive lung disease, asthma and emphysema, the people with serious mental illness are running about they're about 50% to 75% greater than the general population. Higher rates in the red across all categories of illness. Now, some of these are not fatal. Skeletal connective tissue disease, arthritis, is not usually fatal, but it really impacts recovery. If you're aching and you can't move properly, how are you going to get out and be a part of your community? How are you going to be included? How are you going to do the things you want in life? These kind of illnesses not only cause early death, they interfere with recovery from serious mental illness. So overall, what were the causes? 88% of the deaths, the premature deaths, and 83% of the premature years of life lost were due to, quote, natural causes. Cardiovascular disease, diabetes, infectious disease, respiratory illness, all occurring at an unnaturally early age in people with serious mental illness. So, we find that people with serious mental illness are dying younger than they should. Part of it's because they have more risk factors, and smoking is a particular burden in people with serious mental illness. They have the highest prevalence of cigarette smoking, running about 50% to 3/4, compared to down around 23 to 25% for the general population in the U.S. They smoke differently than people without mental illness. They inhale deeper, they hold the smoke longer, get higher levels of nicotine, and undoubtedly absorb higher levels of the other toxins and soot particles. Also, smoking is associated with insulin resistance, and we see higher rates of diabetes another problem with insulin in people with serious mental illness. And most surprisingly, there was an article in the Journal of American Medicine several years ago where it was calculated that 44% of all cigarettes smoked in the U.S. are smoked by people with mental illness. The take-home point for those of you in public mental health is if you want to do something about smoking, you need to do something about smoking among people with mental illness because that's where the bulk of the smoking is. This slide looks at a medical condition called metabolic syndrome, which is really the major driver of the early mortality. Let me talk about what is metabolic syndrome. Metabolic syndrome is having 3 out of 5 risk factors: being overweight, having high blood fats, that's triglycerides, having low levels of the good protective cholesterol, that's HDL, having high blood pressure, or having poor glucose control, diabetes when it gets serious enough. So what this slide shows is the comparison of those 5 factors in people with schizophrenia in a national study compared to the general population. The CATIE study was a national study comparing antipsychotics. It was really intended to find out if one antipsychotic was better than another. But as part of it, they gathered this medical information, and that allows us to compare people with schizophrenia going to well-organized academic practices that can do research to the general population in the U.S., which is shown by the NHANES. Now, why is metabolic syndrome important? Because somebody with metabolic syndrome with 3 out of these 5 factors has the same risk of having a heart attack as somebody that's already had a heart attack. This is a serious indication of cardiovascular risk, of being at risk for a heart attack. And you see for every one of these criteria, whether it's obese as judged by waist circumference, there are higher rates in the people with schizophrenia. 1/3 of the men with schizophrenia make the obesity criteria, 3/4 of the women at 76%. Blood pressure, half in each. So in general, you can, if you check blood pressure in a person with schizophrenia, half of them will have hypertension. About half of them will have high blood fats, low levels of the good cholesterol that also merit treatment. Now the important take home here is in general these days, if anything's monitored, it's glucose, but glucose is the last thing to go. It's the last problem to see in metabolic syndrome. The early problems are obesity, lipids in the blood, fat in the blood if you would, and poor blood pressure control. So overall, back to the big picture, mortality, what's contributing to it? Obesity, cardiovascular disease, diabetes, inactivity. People with serious mental illness are only about half as likely to leave an active lifestyle as people without. Smoking is huge, and substance abuse is an additional risk. So I've shown you some problems. Here's my first inspirational slide. Problems, no matter how great and destructive they seem now, remember, you've only seen the tip of them. I'm going to show you some more problems, some bigger problems. And that has to do with access to health care. Access to health care is a complicated business here in the U.S., and I bet many of you have struggled to keep your own access to health care organized, understandable, and basically doable. It's particularly an issue for people with limited income. There's overuse of emergency and critical care. People with mental illness have lower rates of primary care. They don't get primary care as often. They have lower rates of routine testing. Very poor dental care. Dental care is a tragedy among people on Medicaid and among people with mental illness. And there's been very little integration of what primary care does and what psychiatry and the mental health treatment system does. Often, in fact, usually, the right hand does in fact not know what the left hand's doing. This was shown in a couple of excellent studies by Ben Druss at the Carter Center at Emory. One important study looked at the care of over 88,000 Medicare patients, primarily in California. These were people that they knew had a problem. They were enrolled in the study because they had a heart attack. They were in the emergency room with a heart attack. We know the person has a heart attack. It was diagnosed in the emergency room. When they looked at the mortality after heart attack, it was 19% higher than the general population for any mental disorder, and it was 34% higher for schizophrenia. When they looked at the difference in care, the difference in level of care, the kind of treatment people got during and after the heart attack accounted for most of these differences. People with schizophrenia or other mental illness were less likely to get treated for having high blood lipids, high blood glucose, or hypertension. They were less likely to get a cardiac bypass surgery, which is called angiography or a CABG, coronary artery bypass graft. They were less likely to get drugs that are usually recommended after a heart attack, certain kinds of antihypertensive medication that, independent of blood pressure, lower the risk of heart attack. Those are called beta blockers, ACE inhibitors, aspirin that keeps new clots from forming. And that led to the greater likelihood and higher rates of having a repeat heart attack. So even though it was known they were in the ER with a heart attack, they simply were not getting the recommended care at the same rate as people without mental illness. So I showed you this Katie study again, comparing men and women with schizophrenia to men and women in the general population. Now here's the shocking part of it. I showed you how they have higher rates of hypertension, higher rates of diabetes and poor glucose control. At baseline, 88% of those with levels of blood fat needing treatment were not getting treatment. 62% of those with hypertension were not getting treatment. And 30% of those who had diabetes were not getting treated. This is in academic centers that can do research, yet are unable to diagnose and treat something as simple as hypertension in the people they're doing research on. This is shocking, this is shameful, and this really has to change. So access and quality of care is a problem. It's an increased risk factor in people with mental illness, in part because of patient factors. Serious mental illness interferes with concentration, with memory, with motivation. It's hard to keep all those appointments straight. It's hard to keep all those pills straight. It's hard to do everything you intended to do to take care of your illness. It also can be due to provider factors. Not all healthcare professionals are comfortable working with people that may have different behaviors, that may have different emotional reactions, that may be more difficult to communicate with. And some providers just shy away and disengage rather than giving the appropriate treatment. And then there's healthcare system, the fragmentation of funding, the fragmentation of information systems, things getting paid differently so that it's a lot of work to put all the information together. You know, your average person with a serious mental illness is seeing about a dozen different healthcare providers in a year and is taking about 16 different medications. How are those people all going to know what each other is doing, that dozen providers, and how is that poor patient going to remember to list all 16 meds every time they see one of those dozen providers? We just cannot rely on the consumers to bear that burden of keeping all that organized and in memory. It needs more system factors supporting the providers to give good organized care where they know what they're doing. Another change, a change we have seen recently, is more mental health care in primary setting, and a recognition that psychological distress drives primary care. A lot of the reasons people go to primary care has to do with behavioral health conditions and factors. Most complaints people go to the doctor with, somatic complaints, complaints about the physical body, don't have an identifiable cause. Only about 30% of primary care visits are for an identified medical condition. People go in because they're feeling bad, not because they have a particular illness. And there are more mental health interventions occurring in the primary care system than in the specialty mental health system, which is good because there wouldn't be enough mental health treatment people to go around to treat everybody if they came to mental health first. And the behavioral health problems inflate medical costs and lead to poor outcomes. People who are depressed with diabetes have worse outcomes on their diabetes than people that aren't depressed. Same with cancer, same with heart disease. So, a few observations of what we've gone over. The leading contributors to this premature death are preventable causes. Lifestyle issues are large, and lifestyle is a behavioral choice. Smoking, activity, what we eat, those are behavioral choices. Iatrogenic, meaning the doctor did it. Effects of medications are significant, and inattention by medical and behavioral health professions is also significant. And all this becomes very expensive. Here's a breakdown of the average per person per month, per member per month cost. How much does it cost for your average person in Medicaid each month? For the elderly, it's about $1,284. For the disabled, which includes the serious mentally ill, it's the highest, $1,466. With other populations, like people that are simply poor or children, coming in under $400. It's clear that the drivers here are around being disabled, and mental illness is a huge factor. So, Overall clinical cost drivers: untreated medical illness drives up the cost of care. People to go to the ER when it's too late instead of getting a cheaper primary care visit when it can do them more good. Poor adherence to both medical treatments and behavioral health treatments, and medical errors because there's too many people and they don't know what each other's doing. Administrative cost drivers are there's no coordination of the benefit. There's a lot of administrative burden on the providers. They have to go down chasing the information themselves instead of having it presented to them by the payers. And overall, a fragmented system of care. So, if you're watching today, I assume you're part of the public mental health system. And what is our mission? Recovery for people with serious mental illness. But I've told you we have a problem. And our problem is that early death from physical illness prevents recovery from serious mental illness. Nobody gets better from their psychosis, their depression, their mood instability after they drop dead as a heart attack. So here's my next inspirational slide: stupidity. Quitters never win, winners never quit, but those who never win and never quit are idiots. This is to suggest we need to do something different. We need to change our ways if we want to change these appalling rates of death and illness. So the core principles we're working on here in Missouri are that physical health care is a core service for people with serious mental illness, and that mental health systems have a primary responsibility to ensure access to preventive health care and management and integrate the medical care of the people they serve. Why is that? Because the logical person in a healthcare system to integrate and coordinate care is the person that sees the patient the most often. The more often they're seen, the more opportunity there is to improve things and to coordinate among the others. The other reason, it's the right thing to do. One of my favorite physicians, Oliver Wendell Holmes, pointed out that we should try and kill as few people as possible. And way too many are dying. It's the right thing to do, as well as the cost-saving thing to do. We have been seeing a shift in the safety net paradigm since this report came out in 2004. Behavioral health has become much more central to the general healthcare discussion. We're seeing the traditional community mental health centers focused more on the physical health of the people they serve, pay more attention to metabolic syndrome, start checking blood pressures, and start managing and organizing care. And I'll show you some of how we've approached that in Missouri. There's been a national call for the health status of the serious mentally ill to be a national disparity. One thing the Centers for Disease Control does when they find this kind of health inequity is they recognize it as an official health disparity, something that needs to be tracked over time. Just last year, we had the first CDC report on differential smoking deaths and rates in people with serious mental illness. There's expanded mental health service capacity at federally qualified health centers, the safety net primary care providers, and really a broad recognition within healthcare reform and with all the changes and innovation we see in healthcare of the behavioral health nature of primary care. Primary care is, in a very large part, behavioral health care. A lot of the information I'm going to present next you can find in the 11th technical report at NASPID, the National Association of State Mental Health Program Directors, and it's in a modular, so you don't have to read the whole thing at once. It goes over integration from both the primary care perspective, from the mental health system perspective, and from the national policy perspective. So here's the different strategies that are out there that different organizations are working on. Preferential referral relationship. Community mental health centers, behavioral health providers developing relationships with the primary care clinics in their community so that they're more responsive to each other's patient referrals for service. Formalized screening. Screening for health risk factors, screening for key lab values like poor glucose control or elevated cholesterol. Health information technology-based care coordination. This is huge. Using our ability to aggregate data and then to identify who needs that data to make sure that the health providers have a complete picture of what conditions their patients have and what care they've gotten in the recent past. Co-location of services. Most patients would prefer to get their behavioral health and their primary care in one location. They don't appreciate having to relate to two different provider sets and keep it all straight and help communicate between them. Disease management. Retooling some of our community mental health center services to help with smoking cessation, to focus on obesity and weight reduction, to increase physical activity, and to give diabetes education. And on the behavioral health side, adding a behavioral health professional to the primary care team. And putting the whole package together is the concept of health home, which uses an integrated team, health information technology, co-location at for some things, and formalized screening and reminders to make a whole package to take care of these complicated multi-factor problems. Before going on, I want to say a word about HIPAA, the confidentiality law. If you're going to do care coordination, if we're going to save people from premature mortality, we need to have an understanding that HIPAA allows and does not prevent sharing personal health information. The purpose of HIPAA was to allow sharing of health information, not to prevent it. In fact, health providers can communicate with each other about a person that is in service with both of them, absent patient consent. That's the national regulation. The only exceptions to that are a person with HIV, you can't talk about their HIV status without consent, and substance abuse treatment. Not the fact that the person is a substance abuser, and not all substance abuse treatment. The extra restriction applies to substance abuse treatment by substance abuse treatment organizations that hold themselves out as that. So if you're going to a community mental health center that does substance abuse treatment just when it comes up, but doesn't have a shingle out, doesn't have a sign, doesn't have on its website a big page that said, here's our whole treatment program, that's not under the special extra confidentiality. It's not under extra confidentiality if a person goes to the emergency room intoxicated. Only getting treatment from an entity that holds itself out publicly as a substance abuse treatment entity. If we're going to do care coordination, we have to be sharing information, and HIPAA allows that. We also have to be more culturally competent on the mental health side in how we interact with our primary care colleagues. So I'm going to give you a few points on what drives primary care crazy. Long delays in getting a patient seen for an initial consult, having to wait 3, 4, 6 months to get in to see us. No response back when they refer a patient. This is actually the height of rudeness in medical culture. In medical culture, when primary care sends somebody to an orthopedic surgeon, they automatically get a note back. They automatically get a report. They don't have to send it an extra release of information. Long responses using mental health jargon. Primary care is generally not interested in our 12-page annual write-ups where we go into great detail. They want one page that states in 2 or 3 sentences what the problem is, and then they want 3 concrete things they can do it better, and then they want to know when they should be sending the patient back to behavioral health. They want really very terse communications. And they want a lack of explicit recommendations they can act on. They want something they can do. They're not as much about a detailed understanding of all the psychological nuances of the people they're helping. They want to know what can be done concrete now to make the situation better. And the worst is not responding to a medical record or information request release. Actually, the one worse than that is when they send a release of information and we refuse it and send back saying, no, you have to get the same signature on our release of information. That's really telling them to stick it. And it's unnecessary. It's not required by HIPAA. We need to really be more responsive on these issues if we want them to respond back to us. So the strategies we've been pursuing beyond referral, preferential referral is important, but it's necessary, but it's certainly not sufficient. We're pursuing coordination of care using electronic health records and using case management. We're doing more disease management in the CMHCs for people with serious mental illness. We're co-locating community mental health centers and federally qualified health centers. And we're doing more behavioral health interventions for medical risks in the areas of smoking, obesity, and screening and prevention. On the health technology, we use a lot of different IT tools. I'll show you a few of them shortly. We have 2 partners helping with that, Care Management Technologies and ACS Heritage, now Xerox, provide aggregate reports and also the ability to drill down and look at the full range of detail regarding the care an individual person has got, so you can make an individualized decision about what they need next. I'll go over our integration project between federally qualified health centers and community mental health centers first, and then I'll talk about our health home project. So why co-location? As I mentioned before, patients prefer it, and it raises the chance of a patient following through on a referral from about 15 to 20% to 40 to 60%. That's right. In general, when you ask a person to go see another provider, they will actually do that about 1 out of 5 times, 20%. If you're in the same building, they'll do it about half the time. Still a problem, but about 2 to 3 times better. Second, it builds personal relationships between primary care and behavioral health. Personal relationship is how we all get business done. It's the foundation of any enduring relationship. You're more likely to return a phone call from somebody that you know, and you're more likely to have your phone call returned from somebody that you know is going to see you in clinic later in the next week when you're both in the same treatment setting together. It allows for more accurate understanding of the other's incentives and constraints. Everybody tends to assume that everybody else's care system works like theirs, and that's simply not true. If you're in the same clinic, then you understand the constraints and the incentives that are there, and you're better able to partner when you know what the constraints and incentives on your partner are. I particularly enjoy the opportunity for informal consultation. I've been practicing psychiatry for the last 12-15 years in a primary care clinic. For the 12 to 15 years before that, I practiced at CMHCs or in academic psychiatric settings. And I actually am able to do better psychiatry at the primary care clinic, and I'm certainly better able to facilitate my patients getting primary care. I can run into my colleague in the hall and ask my question right then when I never would have remembered or taken the time to put in that extra phone call, to write a note, to send a letter. You just end up talking a lot more and communicating a lot more about care and patients when you run into each other and have those informal consultations. And of course, the single clinical record reduces error. It turns out patients treat their providers a lot like kids treat their parents. There's some things you tell mom and not dad, and there's some things you tell dad and not mom. There's some things they'll tell their primary care physician and not their psychiatrist, and vice versa. In general, I find the best place to find out how my patient is dissatisfied with my treatment is in the primary care notes, and conversely, the best place for primary care to see what the patient isn't taking of their meds is in my notes, because patients are nice to their doctors. They don't want to say unpleasant things, so they tell us happy things, which isn't always what actually goes on. So our integration initiative, our goal was to integrate primary care and behavioral health. The way we structured it is you had to be a FQHC, a federally qualified health center, and a CMHC to apply. Successful applicants would agree to co-locate. They would agree to add mental health services from the CMHC to the primary care center, and they would agree to add primary care services at the CMHC from the primary care provider. They each got $100,000, but they could only use that $100,000 to buy services from the other entity that had to be at their clinic and on their clinical record. We started this back in 2007, began funding it in January 2008. We also did some planning grants for 6 other sites. We've been continuing it ever since. There are multiple models that the sites have used. Some have implemented traditional mental health services at primary care, things like brief therapy and psychiatric evaluation and med management. And there's been some new approaches at the FQHCs. Things like SBIRT, brief screening and intervention for alcohol and drug programs, which is shown to save twice as much as it costs. Focuses on excessive drinking before people actually go to the level of alcohol abuse or dependence. And embedding a behavioral health consultant on the primary care team. This is a different kind of behavioral health practice. It doesn't involve sitting by yourself in the room with the patient. You go in with primary care. You start off with a joint conversation. Primary care usually moves on and you spend a little more time with the patient. You may follow up once or twice. Very focal, very time limited. It's about the problem right now. Problem comes up again, they'll come back, you can work on it again. There's also been provision of traditional primary care services at the CMHC by the FQHC. And we've recently implemented the community mental health center-based healthcare homes that I'll talk about later in the presentation. We got the embedded behavioral health consultant from Cherokee Center in Tennessee. They've been doing it for about 15 years. It is a real-time behavioral and psychiatric consultation available to primary care. It makes primary care much easier about broaching some of those tough questions about past trauma and abuse, about drinking, about depression, without worrying that they won't be able to stay on their clinic schedule or won't know how to deal with it. It's also focused on behavioral intervention right in the primary care setting, and it encourages patients' responsibility for living healthy, for increasing physical activity, for changing eating habits. We've worked on enhancing provider-provider communications. Co-location and facility design is important. If you co-locate, do not put primary care off in the corner or do not put CMHC care off in the corner. You want them interspersed. You want to have them sited so they have to be walking past each other all the time. Integrated charts are important. You should not be putting the behavioral health information in a separate section of the chart. You want them to be reading the primary care notes that occurred since the last behavioral health visit so they can start their next note and have the full picture. Regular face-to-face verbal feedback between providers, I've already covered. Brief consultations. If you're in the same location, you can knock on the other person's door, say, can you step out for a minute? And you know, the interesting thing is that's considered a big traumatic insult in therapy in a CMHC to interrupt a therapy session. Oh my God, you know, they'll have a regression. You know, it could become suicidal if we get interrupted, and they'll just be endlessly rudely interrupted and they may not come see back again. It doesn't happen. It doesn't happen. That's accepted culture in primary care. All of you in a primary care visit have had your physician interrupted, stepped out for a minute, came back, continued the intervention. It really is a more relaxed, natural way to proceed with health care than holding the therapy period as something that must be pure and always the same duration, irregardless of the duration of the level of need at that visit. Formal team case conferences. It gives you a chance to sit down with your primary care colleague and discuss the 4 or 5 people that worry you both the most. Telemedicine. A lot of the co-located areas are also using telemedicine to provide the same capabilities to some of their outlying sites, particularly in rural areas. I myself am always on beeper from my primary care clinic. My primary care colleagues can call me up and we can have brief conversations that really can get them out of a sore spot. The behavioral health consultant in primary care manages psychosocial aspects of chronic and acute medical diseases and behavioral health, applies behavioral health principles to addressing lifestyle and health risks. We are supposed to be the people best at changing behaviors, and that should extend to things like obesity and smoking. A lot of emphasis on prevention and self-help, a lot of self-management, builds resiliency, encourages more personal responsibility for health behavior, and allows for consultation and co-management. They address psychological problems like anxiety and depression, also substance abuse disorders and risk reduction through the SBIRT process, and the psychological components of physical illness. Of course, it's common for people to be psychologically distressed when they have new diagnosis of a major illness, diabetes, a heart attack. Their life has just changed forever, and that needs to be addressed, and they need assistance in dealing with it. That's something the behavioral health consultant can be very useful for. Non-adherence. When you look at rates of non-adherence, they're just as bad for chronic medical conditions as they are for behavioral health. Another major role for the behavioral health consultant is working with patients that are unable to take their medications regularly or follow through on appointments. So our progress to date, we have more organizations that are both a CMHC and an FQHC. We actually are now up to 3 CMHCs that have new FQHC status. We've had 1 CMHC and FQHC merge. We have more FQHCs choosing to contract with their CMHC for behavioral health services in areas other than are paid for by our grant. They decided they liked working with each other. We have a couple more CMHCs applying to become FQHCs, and we found a way to leverage the funding by 30% using a little-known federal funding mechanism that really is a way to get additional money for serving the uninsured with federal participation. That's our FQHC-CMHC integration project. I'm going to close by talking about our Health Home project. Our strategy here is to use health technology to support the service system. Care coordination, we believe, is best done locally by a local provider. People respond to personal relationships, and they'll do much better with somebody they know who's been in their home than with a voice over the phone with a stranger. For that reason, community support workers, the mental health community support workers, are most familiar with the consumer, with the patient. They're ideal for doing care coordination of the general medical care. But changing our system, what's been key has been adding primary care nurses. Primary care nurse liaisons, which in each CMHC have really been transformative. They're very good at helping other staff get organized. They come with primary care expertise. They're good for teaching both staff and patients, and they're good for communicating with the rest of the primary care system. We've also added primary care physician consultants. I'll say more about it in a minute. And it takes a lot of training, an awful lot of training. Who's eligible for the Community Mental Health Center Health Home? Well, people that have 2 or more chronic conditions or at risk for another, or a serious persistent mental illness, which is at a CMHC just about everybody, because everyone that doesn't have a serious persistent mental illness usually has some other mental illness or substance use disorder, plus one of the medical factors, which includes simply being overweight. Health homes have to do 6 required functions. They have to provide comprehensive care management, coordination of care, health promotion, managing transitions of care, inpatient to outpatient, providing individual and family support, and referral to community services, not just medical services, but those general social services that are also major determinants of health. Getting people food, getting them heating assistance, making sure they're housed. You can't be healthy if you're homeless and cold. What is a healthcare home? It's not just another service line. It's not just a Medicaid benefit. It's really a different way of doing business for either a primary care practice that's doing it or for a community mental health center. It's about making decisions more by data as opposed by what's the individual complaint today. It's about making decisions based on the whole population you serve rather than just one patient at a time. It's about thinking data and using data more to direct the care and implementing evidence-based decision points to find where those care gaps are that need to be addressed and filled. So we decided to give it a try. We took the risk. If you never try anything new, you'll miss out on many of life's great disappointments. And actually, the first care coordination project we did back in 2005 was no better than usual care. Health homes are actually our 4th attempt. Our 2nd and 3rd we did better on, and we're doing even better on this, our 4th one. But if you're not trying new things and failing, if you're not failing regularly, you're not trying enough new things. So don't be afraid of taking a risk. Don't be afraid of failing. That's how you get places. So who are these new health home team members? Well, a health home team consists of the usual mental health team, the psychiatrist, the mental health case manager, the community support worker, but we've added a few people. We've added a healthcare home director. It's their job to champion the healthcare home transformation. It involves changes in work processes and policies. There needs to be somebody in contact with access to the executive team that reminds them that they need to change, that they intended to do these things. They oversee the daily operation of the healthcare home. They track enrollments, discharges. They track use of all the information, the reports they get of who needs attention to what point in their diabetes, who just got in the hospital and will need follow-up when they leave. So they coordinate management of the health information technology tools and develop relationships with hospitals and primary care practices around the community. They get the health home connected to the rest of the healthcare treatment system. The nurse care managers are really the backbone of the operation. These are primary care nurses. They champion healthy lifestyles and preventive care, and they provide individual care coordination. They review the client records. They do a health risk assessment at least annually. They use the IT tools to figure out who isn't adhered to their medication, who's on an antihypertensive and hasn't filled it in time, or their antidepressant. Who hasn't had their annual or their periodic testing for that diabetes blood sugar test. And then they're able to decide, are they going to contact the patient? Is the mental health case manager going to contact the patient? Do they need to go to see primary care to get that proper inhaler that they're not on right now? They are the monitor and the quarterback. helping the rest of the team make sure that you get those chronic medical issues on the treatment plan and part of the mental health treatment plan. Because, you know, we like to tell our primary care colleagues that the brain's part of the body. Well, that means we need to also be taking care of the rest of the body, and our mental health treatment plans can't just be about the brain. They need to have some general medical care issues on them, especially for people with multiple chronic medical conditions. We've added primary care physician consultant time. This is a primary care physician that's there available to consult with the nurse care managers, to consult with the psychiatrists, to consult with the mental health case managers and supervisors about which conditions to target, how to select patients where you can make a difference, to focus your attention and efforts on, to communicate with other primary care physicians or medical specialists about particularly difficult situations or illnesses, and to start a relationship, to get your community mental health center in a relationship with those other medical care providers. They will have primary care buddies around the community, and they can help make introductions. As I said before, the team still consists of psychiatrists, qualified mental health professionals, psychosocial rehab workers, community support workers, but now they're collaborating with the nurse care managers and have access and support from the healthcare home director and the consulting physician and the primary care physician consultant to be able to address lifestyle changes and medical gaps that have been killing their patients. So, comprehensive care management, I'm going to go through the 6 functions. I said the 6 functions were care management, care coordination, health promotion, transitions of care, individual family support, and referral. The 2 most important and newest things are comprehensive care management and coordinating the general medical care. We're used to coordinating the mental health care. What is comprehensive care management? It's identifying and targeting people that are at high risk, finding out their health care gaps, using treatment guidelines to figure out what care they should be getting, and looking for those gaps when they're not getting it for each individual consumer. How do we do that? The nurse care managers screen annually for general health risks. Prescribers screen and monitor for metabolic syndrome. We screen everybody for metabolic syndrome at least annually, checking their blood pressure, their glucose control, their blood lipids, checking for obesity. And we're able to get their previous medical care from administrative claims, from their insurance claims. If you think about it, your insurer knows more about your health care than any individual health care provider, because the insurer gets to see all the care that occurs, not just what they do. So we take those Medicaid claims and we make them into a file and a short-term medical history that lists for every individual all the meds they've had for 3 years, all the ER visits, hospital, outpatient visits, the diagnosis, who treated them for what, when, and where, which is really what a medical history is about. We get clinical values from the metabolic screening, height, weight, lab values, and we combine them in a searchable database that is the Electronic Health Record Disease Registry. That's available online as the PROACT tool to all providers. They can use it both in aggregate to find all the people, say, that have high blood pressure. Then among them to find who's on an antihypertensive and not, and among those to find who's been taking their antihypertensive or not, because if you don't fill the script, you can't take the med, and you can find that out from claims. Here's the things we collect in our metabolic screening and on the registry: obesity, cholesterol, triglycerides, blood pressure. We combine it in the registry, identify the gaps, and then the nurse care managers go out and work with the mental health team to decide who's going to do something about that gap, who's going to bring it to the attention of a medical specialist, the psychiatrist, primary care, for action. Some of the performance indicators we follow are use of inhaled corticosteroids by people with asthma or emphysema, adherence to 8 different classes of medication, following up with people within 72 hours after hospital discharge, control of blood pressure, control of glucose, weight, substance abuse, smoking measures. Let me say a little about the inhaled corticosteroids. Actually, we found out that getting a person better control of their asthma improves their mental health. Why would that be? Well, when people are on the wrong kind of inhaler, a rescue inhaler, they're puffing on it all the time. And those Allopen inhalers make people nervous and interfere with sleeping. They feel jittery and they don't sleep. So they go to the psychiatrist and they want sleep meds and they want anxiety meds, and now they're not only on the wrong inhaler, but they have 2 other meds they don't need. You get them on the right inhaler, corticosteroid inhaler, that prevents the wheezing from occurring to begin with, ER visits go down and they sleep better. That's how the interactions work between behavioral health and primary care is one example. Health homes get a lot of information reports. They get reports on what the provider, use by provider. They get service patterns, average costs, medication possession ratio. That's how we measure medication adherence. If a person's only filling their meds half the time, then their possession ratio is 0.5, half. And they couldn't be taking it all the time because they didn't fill it. We look at trends over time, trends in services, our hospitalizations going up or down. We recently had a report showing our rehospitalizations appear to be trending down in just the first year of this program. So initial results, I told you about that asthma inhaler problem. When we focused on that for 2 quarters, we were able to reduce the percentage of people not getting the appropriate preventive inhaler by 45%. This is real improved healthcare. This is something closer to the recommended guidelines, and we see this as closing that gap where seriously mentally ill people aren't getting the recommended treatments to where they're getting recommended treatments at the same rate and hopefully ultimately better rates than the general population. That's care coordination, care management. Care coordination is making sure that the different providers involved in a person's care all know what each other's doing. It involves planning for hospital discharge, helping people schedule appointments, helping them keep their appointments. And you know those IT tools, where you can print off a history of everybody's medical care? It turns out that the other medical providers are a lot happier to get a referral of a mentally ill person when they come with a pre-printed medical history. They've just saved about an hour of exam or a half hour of interview time asking about old diagnoses, old meds, and they can just have that. It makes them happier to get referrals of people from CMHCs with mental illness. To remind you again, I can't beat this horse too much, HIPAA allows this. You cannot coordinate care. Health homes are required to coordinate care. It's a core service. And you have to get you have to come to understand that HIPAA allows sharing and does not prevent sharing. The health homes are using a lot of peer specialists and wellness approaches. Peers are excellent role models in helping with the obesity reduction, smoking cessation, in coaching patients how to bring issues to the attention of their treating healthcare providers. Make a list of what you want to talk about at that next visit, empowering them to be more active in managing their own care. And that's really a form of shared decision making as well as self-management. Another IT tool we use is, it turns out your insurer is usually the first person to know you just got hospitalized. That's because every time you go to the hospital, they're required to call up your insurer immediately and ask for if you're covered for that. And the insurer will say, oh, pneumonia, okay, you get 3 days covered. That means the payer knows. In our case, the payer is Medicaid. Since Medicaid knows, we're able to take that data overnight, every night, automatically sort it in a computerized algorithm to which out into the health homes, because we have a list of who's in which health home, and then an automated email goes out to the health home directors of everybody that got admitted the night before. This is very helpful. How can you follow up with somebody within 3 days if you don't know they're in the hospital to begin with? This is really something that all insurers should do and haven't been doing. Why not share that information with the providers that you want to be providing good care? Why do payers keep all this information to themselves and not empower providers to give better care by making the information they have available accessible for use in treatment and not just for payment? So, as I said, this is really about practice transformation. This isn't a separate service. This is about focusing on the whole person, on overall health. It's about being more medically oriented. It's about getting in people quicker. One of the early interventions, improvement processes we did is the Coalition Community Mental Health Centers was very effective in implementing open access scheduling across the state. Changing your no-show and cancellation policies, getting more data reporting and treatment planning. I'll show you a few of our outcomes and then we'll wrap up. We track cost, we track quality of care, things like medication adherence. There's a set of standard national healthcare quality measures called the HEDIS indicators that we track some of those. We look at clinical outcomes like avoidable hospital admissions and ER visits. And the patient experience of care is tracked using the mental health inventory, the MISIP, that's part of the block grant. We do this with partners. We could not do this alone. This is a partnership between MoHealthNet, our Medicaid agency, the Missouri Department of Mental Health, the Coalition of Community Mental Health Centers, Missouri Primary Care Association, and our private vendors, Care Management Technologies and Xerox's ACS division that help us with our data analytic tools. I'm often asked, what made this possible? How do you get all this together? And in the end, it's really about relationships. It's about basic trust of your partner and being willing to take a risk together. What made it possible was good working relationships between the people I just listed and with the state budget office and the state agencies at Medicaid and Department of Mental Health. You can't do this alone. You need people, and you need to trust the people you're working with and help them with their problems. So, we hear a lot about change in the healthcare system, change in the economy, change. When the winds of change blow hard enough, the most trivial of things can turn into deadly projectiles. So where do you want to be in this picture? Do you want to be the thing that's struck by the deadly projectile? Do you want to be the projectile and wang into something else? I want to be the wind. We can be the wind that causes change, that reverses this epidemic of death. Thank you for your time. I'll take questions.
Thank you, Joe. Give people a moment to send questions into that internet chat site on the right side there. One question that comes to mind is, what kinds of barriers did you face or obstacles did you face as you attempted to roll this out with folks?
I think the biggest barrier, it's complicated, and it was helping people really get their heads around it. It did take explaining the nature of the problem and the nature of the interventions. People get all these information reports on disease gaps, and their initial thing is, well, that's interesting, sounds scary, now what the heck do I do with this? So a big challenge has been helping the health homes figure out how to integrate this into their usual workflows, into their day, into their staffing patterns.
I think we filled our hour, and I think people have decided that that was the hour that they were going to spend with us this afternoon.
Okay.
So we will say goodbye to you. We'll say goodbye to you folks today. I know that several of you did have some technical issues. We did record this presentation. We'll send you a link to the recorded version of this presentation, probably in an email either tomorrow or the next day. So look for that from us. But we appreciate all of you that stuck around with us this afternoon. Our next web conference is going to be next Thursday, and we deal with equine-assisted psychotherapy. And another speaker from the Spring Training Institute, Linda Riches, will be with us on Thursday afternoon right here. So please stay tuned to that. We'll send out an email announcement about that. The links to the CEUs will stay open and be provided in a follow-up email, as will a link to the slides. And we thank you for your time this afternoon. Joe, as always, thanks for your time.
Thank you, Tom, and thanks to the viewers.